This program is brought to you by Emory University.
All right, good morning. Dr. Taylor couldn't be here this morning, so he asked me to introduce our speaker. It's my pleasure to welcome Dr. Jaime Vengoechea Barrios here. He is assistant professor in the departments of human genetics and medicine. He joined the faculty in 2015 from Little Rock, Arkansas. He did his medical school training in Bogota, Colombia, and completed a residency in internal medicine and medical genetics at Case Western Reserve University in Cleveland. He's board certified in both internal medicine and medical genetics and clinical genetics. He specializes in clinical genetics for adults and is going to talk to us this morning about cardiovascular genetics. Welcome.
Thank you. Morning, everyone. Start with, so the overview of what I'm going to try to cover today, and I might not get to everything, is genetics and benefits of genetic testing, and we're going to spend some time in looking at all the different genetic tests that could be done. I'm going to give you some examples of how genetic testing can be used in the realm of cardiology, hypertrophic cardiomyopathy, aortic aneurysm, and hereditary arrhythmias. They asked me to do some pre-test questions, so here they are. Do you guys use a web app to answer these, or? Okay, all right. All right, so which of the following is a true statement? Incomplete penetrance means not all carriers manifest the same range of symptoms. GWAS is a test with high clinical utility. Microarrays can identify point mutations. Mutations outside of the coding sequence can cause genetic disease. So think about that one, and we'll revisit them at the end. Question 2, which condition has autosomal recessive inheritance? Jervell-Lang-Nielsen, Brugada, Timothy, or Romano Ward? They all have long QT. Well, not Brugada. Question 3, true or false? It is possible to be homozygous for mutations in genes that cause hypertrophic cardiomyopathy. So, in medical genetics, we use molecular genetics to more accurately prevent, diagnose, and treat disease. And what we try to do for the patient is place genetics in simple terms that they can understand and help them manage the expectations from a genetic test result. It is very important that they understand that this is not a yes or no test, and this is not a value test. You don't get a number out of this test. And there are serious interpretation difficulties with genetic testing that many times when the patients have not had a chance to meet with someone from genetics before they have the test, they don't understand and can cause a lot of frustration once an uncertain test result gets delivered back to the patient. Also important for the patient to understand how the test result may change their management and that of their family. And we go over the medical legal implications of genetic testing. And I guess another bullet is we try to help the patient navigate the insurance system for these genetic tests. So I have this slide here. Sort of, first it kind of reminds us of the basics of genetics, of molecular genetics. Genes are found in the DNA strand, and a gene has a specific structure within the DNA. You have exons, which are regions of the gene that will end up in the final message, and they're interspersed with introns, which are regions of the gene that will not make part of the final message. And you can have genetic disorders caused by mutations in the introns, especially if they are in the boundaries between exons and introns. So the DNA is transcribed into a pre-mRNA, which still contains the areas of the introns. The introns are then looped out, and you have a final mRNA. That mRNA is exported out of the nucleus into the cytoplasm, where it's translated by ribosomes into protein. Some basic concepts that are sometimes easy to forget and confuse are, first is penetrance. So penetrance simply means the percent of individuals with a mutation who manifest the disease. And it's very rarely 100%. There's a typo in the word rarely. Okay. Expressivity is the degree to which each individual who already has a mutation and is affected, to the degree to which they are affected. So penetrance is turning the light on or off for the presentation of the disease. Expressivity is how bright that light is once it has been turned on. Locus heterogeneity is when a single disease, a single phenotype, can be caused by mutations in genes at different loci. So different genes all cause the same disease. So for example, hypertrophic cardiomyopathy. Allelic disorders, when you have different diseases caused by mutations in the same gene. And we'll see an example later with long QT and Brugada. So the first genetic test that became available was karyotype, which is simply an image of the chromosomes. Karyotypes have gone a long way, and now you have high-resolution karyotypes. But for most purposes, karyotypes are not going to be that helpful in the realm of cardiology. I can think of, for example, a coarctation of the aorta, and you think that this might be a mosaic Turner, then a karyotype might be the best test in that situation because they're very good at picking up mosaicism. Microarrays allow for the detections of small deletions or duplications across the genome using special probes that are interspersed, regularly across the genome. There's extra probes in the areas with more genes. And the microarrays have gone from 3,000 probe arrays to 1 million probe arrays in 5 years. So these days, the smallest of deletions can be picked up by a microarray. However, it does not allow you to find point mutations. It does not allow you to find intragenic deletions unless they're fairly large. Sanger sequencing was the traditional test for point mutations, and this test has been done, since the 1980s. It is very reliable. It is more time-consuming. You can only do, one exon at a time. And so it is relatively expensive compared to the next generation sequencing, which became available in 2010. And then, of course, now since 2012, you can do a sequencing test of the whole genome or of the whole exome. The exome is the part of the genome that has the exons. So microarrays are more useful in multiple congenital anomalies like cardiac malformations, or when a patient has learning disability and some other rare phenotype, and it can help identify deletions and duplications not seen in karyotype. This is an example of the automated sequencer for behind Sanger sequencing. So you have these special stop or termination signals that cut the DNA strand and emit a particular frequency that can then be detected by the machine, and you line up your sequence. Now we have next generation sequencing, where thousands of genes can be sequenced at the same time for the same cost as a single gene. For most purposes, the massive parallel sequencing has been the technique that has sort of taken over, and the others are either still in development or have been dropped. It often requires Sanger sequencing to cover gaps that were not covered by the original next-gen test. And the interpretation is very complex. You really need a machine to help you interpret this. And you can use next-gen sequencing to develop panels. So a panel is just basically a collection of genes that the lab thinks is a good idea to test for a particular indication. So for example, if somebody has a dilated aorta, you can check all the genes for aortic root dilation, Marfan, Loeys-Dietz, Ehlers-Danlos, etc., and just throw them all together in a panel. Panels could have more targeted coverage for the genes you have. You're using the whole machine targeted at the particular panel. But as technology has evolved, these days mostly panels we'll sequence all the exome and we'll just report back to you the genes that you asked us to. That's kind of the way things are going, just by automation and efficiencies. What can vary between panels is the technique they use to detect deletions and duplications. And so often I will look into the nitty-gritty detail of how a lab is doing they'll do before I decide which panel to choose. And so that makes panels vary greatly from lab to lab. So no two labs that offer the same panel are offering you the same thing. And some labs will throw in genes that they promise they can sequence, but they really can't. So there's some need to be careful there. So this is how the next generation massive parallel sequence works. Basically, you get these small snippets of sequence that are lined up by the computer. And basically, for example, in this one, you have one C and all of these are T's. And this C might be a sequencing error or maybe a legitimate C, and that's where you need the help of the computer to figure out exactly how much signal you're getting for those. However, in this one, half of the strands are giving you a T and half of the strands are giving you a C, so this one is a more reliable, this person has a mutation in that locus. And this gives you the relative cost per genome in the United States. So in 2001, it was $100 million, and now in 2013 is somewhere around 5,000. So the cost of this testing has gone down dramatically. Some of the practical aspects of genetics testing. Next generation panels can be more practical and than doing gene by gene, and usually the price is the same or cheaper versus selecting the individual genes. The more genes you test, the more likely you are to end up with a variant of uncertain significance, which is basically there's a variant in the patient's DNA when compared to the standard DNA. Nobody has a standard DNA, so obviously we are all going to have variants when they check our genes. It's a matter of deciding whether those variants cause disease or not, and sometimes we just can't tell. And so once you are into the area of 20, 30 genes in a panel, you're about a 20% chance of having a variant of uncertain significance with that test. For insurance coverage, it changes from day to day, week to week, and insurance company to insurance company. Sometimes the policies have straight up genetic exclusions and there's nothing you can do about it. There are more options for patients to self-pay for genetic testing these days. There are labs that are offering panels for $400 for the patient out of pocket, and that might be an option for some patients. The labs that do the test can help you often with the pre-authorization part. Of course, pre-test counseling and consent are very important because it's not a simple positive or negative test. And GINA is a federal law that offers protections against discrimination by health insurance companies, but not by life insurance companies based on genetic testing results. So if a patient doesn't have life insurance and this genetic test might establish a diagnosis for the first time, they may want to get the life insurance policy first. So this is an example of a panel. This is a ARVC panel, and you can see that it includes dozens of genes. Some of them have to do with ARVC, others are in the differential diagnosis of ARVC, and some I frankly can't tell you why they are on that panel, but there they are. But there's more than the 8 genes that have been well described for ARVC in this panel. So NKX 2.5 is related to congenital malformations, maybe atrial fibrillation, but it's thrown in there. So how do we decide if something is pathogenic or benign? Well, if a particular misspelling co-segregates with disease or has been previously reported in affected individuals, then it's probably pathogenic. Absent from controls. So now all the labs that are doing exome sequencing are reporting into a database called EXAC. And so that database is up to 120,000 people that have had all their exome sequencing done. So we have pretty good control information. So if a particular variant turns out to be present in 1% of the population and your disease has a prevalence of 1 in 10,000, then you know that that variant is probably not causing disease because it's way too frequent for that. There are programs that can help predict whether a variant alters protein function and also can tell you if it's in a region that's conserved between species or if it's in the key region of the protein. And then finally, the gold standard, and it's not here, is to do functional studies, but that is very often not possible unless you're in a research lab. So the greatest clinical utility comes from a pathogenic test, and the least clinical utility comes from a no mutation identified test, because then you're back with no diagnosis at all. This incredibly complicated algorithm that I'm not going to go through is the ACMG 2013 recommendation as to how to decide if a variant is benign, deleterious, or uncertain. And it got changed 2 years later. And it's now even more complicated. So let's just leave it at that. Very complicated process. So exome sequencing looks at all 20,000 genes. So if I order an exome on anybody in this room, we're going to get 40,000 to 60,000 variants per individual. And you have to use a computer program to narrow it down, and it can help you narrow it down to maybe something like 200 candidates, and then that has to be manually curated. So if you wonder why an exome takes 6 months to come back, that is why. It can be useful to identify new conditions for the first time. And to be really, really useful, you really need both parents to provide a sample so that you can throw out, like if both parents are unaffected, you can throw out all the variants that are present in the parents, right? If that's not possible, then at the very least 2 first-degree relatives. If you don't have that, there's no point in doing a whole exome, but you can do a clinical exome. The clinical exome looks only at the 4,600 genes that are associated with disease, and so does not require parental samples. And again, after filtering, it will be about 400 variants per individual, even on a clinical exome. Genome sequencing is interpreted exactly the same as exome sequencing as of now. You just get more data, but you can't really analyze it at all. Every lab that's offering genome sequencing is taking that genome sequence and they are filtering out anything that's not in the exome, and they're just analyzing the exome because there's really no computing capabilities or really math knowledge to interpret a genome right now. So often a confusion is between GWAS, which is genome-wide association study, and genome sequencing because they both use the term genome. A GWAS is a massive case control study where 1.5 million SNPs are used, and each one is basically used as a risk factor. And then you analyze those risk factors against disease being present or not. The SNPs are just tags that point at a general area of the genome that is of interest, but they're not necessarily the culprits of the disease. And so often you get these massive GWAS studies and like, we found a SNP in 9p13.3, but we're not exactly sure if it's this gene that's to the left or it's this gene that is to the right, and there are many examples like that in GWAS studies. Genome sequencing sequences every nucleotide, so instead of having 1.5 million like you have in a GWAS, you have 3.2 billion points of information, and the idea is that the sequence change that you report back is the culprit. So basically, GWAS is a research test, not a clinical test. And here's an example of a GWAS on coronary artery disease, and they found a locus in 9p21. And so this is called the Manhattan plot. So each individual point is a variant within the genome, a SNP, and because you're testing so much, your P for significance is not 0.05, it's 10 to the power of minus 6. So this is the threshold for genome-wide significance. And then clearly this place here is very significant, 10 to the minus 55 or something. So to the minus 56. But then when you look at the ORs for this locus, the odds ratio is somewhere between 121 and 128. So all this effort, 75,000 people tested, to come up with a locus that has a very minimal change in the risk for coronary artery disease. So GWAS has, by and large, been a big disappointment. So tests that are clinically useful. Stuff like 23andMe that you may have heard about online that will look at your risk factors and will tell you what pills you have to take and what vitamins are good for you, and don't, you have to be on the, expensive form of cobalamin that we will sell to you. Well, those are not helpful, okay? Have no clinical utility. Tests with high clinical utility are the ones that are used to look for Mendelian or monogenic disorders, and they can help establish a diagnosis if you have a broad differential, so for example in some of the arrhythmias. It can give prognosis information in certain diseases like double heterozygous with hypertrophic cardiomyopathy, and it can help guide management, for example a lower threshold for surgery in patients with low SDs, and it can help to identify at-risk relatives that need to be tested in a cost-effective way. And for example, this cost-effectiveness has been proven for hypertrophic cardiomyopathy testing. Which brings me to hypertrophic cardiomyopathy. So it has a frequency of 1 in 500, which is way more frequent than most of the genetic disorders we see. This is probably one of the most frequent genetic disorders. You have a hypertrophic, non-dilated left ventricle, and now other explanation for why it is this hypertrophy. That's basically the definition. And comprehensive screening can detect mutations in up to 60% of families. It used to be about 50%, but now with additional genes, it has pushed up to about 60%. Sometimes you'll see the term HCM used for LVH from whatever cause, and that can lead to confusion, and we try to reserve the term HCM for the genetic form. And there are ways to suspect this, which I'm not going to explain to the cardiologist, honestly, but an MRI can somewhat help in risk stratification, for example, the late gadolinium enhancement in hypertrophic cardiomyopathy, or if there's an apical aneurysm. And then genetic testing, especially someone who's pre-symptomatic or an at-risk relative, can be very helpful. And so, of course, here's a classic example of the hypertrophic cardiomyopathy. And what you can see on the left are that the fibers are not respecting the normal architecture of the myocardium versus the left, which is a normal heart. And this is a source of arrhythmia, which is sort of the scariest part of hypertrophic cardiomyopathy. So up to 18 genes have now been identified as causative. I use that sort of up to because there's always a few genes that are like genes of unknown significance. Well, it looks like they cause hypertrophic cardiomyopathy, but we're not entirely sure. All of these are dominant, have autosomal dominant inheritance, so having one change in the 2 copies of the gene is enough to cause the disease. 70% of those mutations are in MYH7 or in MYBPC3. Each lab reports those results differently, but the 2015 ACM gene guidelines that have sort of come up with this standard way of reporting results are getting more acceptance. There are a few labs that still don't like it and don't use it. They're not forced to. But in the end, it's basically a probabilistic result. We think this is very likely to be causative of disease. We're certain this causes disease. We don't know. It's still a probabilistic result. And those results can be updated. We called you a variant of uncertain significance 3 years ago, but we now know that this is benign, for example. That can happen. So the testing strategy that I like for HCM is to start with these 2 genes, which account for 70%. And if those 2 are normal, then do the rest, right? From a practical standpoint, the way it is these days, all the genes are being tested. They're just analyzing these 2, report that back. We didn't find anything. We'll look at the others. That way, if we find a mutation in one of these 2 genes, we don't have to keep looking at the others and avoid getting variants reported back that are of uncertain significance and then that just cause more stress and confusion on the patient. It's not that it really saves money, but it saves patients stress and anxiety. So that's what I've been doing. Here's a list of the 18 genes that have been related. I'm not going to go over it. But one important thing is that most of these are part of the sarcomere. And MYBPC3 is this myosin binding protein C. 35% of mutations are caused by MYBPC3. Then MYH7 is part of the beta myosin heavy chain. So that's 35%. Then some of the others are here, like actin, alpha actin, 5%. The troponin genes, so troponin I, C, and T, all have been related to hypertrophic cardiomyopathy, each accounting for less than 5%. So genetic testing is a cost-effective way of identifying at-risk relatives. It can help somewhat with the differential diagnosis. For example, PRKG2 is a glycogen storage disease that has an association with WPW. LAMP2 is a lysosomal storage disease with a lethal course in which the ICD is pointless, basically. These patients do not respond to the ICD, and so you would avoid a procedure that they don't need and would get no benefit from. Fabry disease is X-linked. It's not truly a cause of HCM, but it causes hypertrophic cardiomyopathy. It's just not, the typical mechanisms we think about. And Fabry disease is actually treatable because there's enzyme replacement therapy. The questions about prognosis. So if you're a compound heterozygote, if you have mutations in more than one copy of a gene or in two genes, in two different genes, then you can develop disease. That is particularly severe. So in general, for cardiomyopathy, I would say that patients with HCM you should think about genetic testing in them. Patients with dilated cardiomyopathy with an unusually early presentation, a strong family history, or no obvious cause. Syndromic cases, I put it in between quotes, but basically cardiomyopathy and other affected organ systems, something that just doesn't add up. So this patient has, hepatosplenomegaly on top of their cardiomyopathy that I can't explain. Those cases sort of bring up the possibility of something genetic, perhaps something metabolic, perhaps something treatable. Sometimes a patient presents to you with a genetic test result already. That's confusing, and in those cases, we could maybe help interpret it. And I just put these slides as an example of how patients with LAMP2 or Fabry could look exactly like patients with the other forms of hypertrophic cardiomyopathy phenotypically, and genetic testing is the only way of telling the difference. And these are just MRIs showing that sometimes the hypertrophy can be very sort of isolated, like in this case, which is pretty focal here in the septum, or sometimes you can have the two walls grow into each other and basically create two chambers. So I'm going to turn to aortic aneurysm. Doing okay on time, I think. So the major genetic causes of aortic aneurysm are Marfan syndrome, Loeys-Dietz syndrome, isolated familial thoracic aortic aneurysm, and then there's vascular type EDS, and there's some of the cutis laxa genes. But cutis laxa, basically you have this very stretchy, redundant skin that gives away the phenotype in those cases. But those patients can also have dilated aortas. So Marfan syndrome. So a very frequent referral to me is rule out Marfan, and they come without an echo. And so I can't rule out Marfan, because the basic definition from the Ghent criteria mostly requires you to have an aortic aneurysm to have Marfan syndrome. So if the aortic root has a z-score greater than 2, so who reads echoes here? No one? Okay. Have you reported z-scores out?
Not on the adult side.
Not on the adult side. So if it's for rule out Marfan, we need the z-score, even if it's on the adult side, which often we don't see. And like, well, it's 4 centimeters, it's borderline. I'm like, yeah, but is this guy, 2 feet tall or? So, 2 meters. I still think in metrics, so 2 meters is what I meant to say. So they have to have the large Z score plus one of these three, ectopia lentis or a fibrillin 1 mutation, which you don't see in 100% of patients with a diagnosis of Marfan based on Gantt criteria, or a clinical score of 7. The clinical score is based on the musculoskeletal and physical exam findings. So note that having a clinical score of more than 7 does not get you to a diagnosis without an echo. Or having ectopia lentis and a known pathogenic fibrillin 1 mutation. If there is a family history, then having ectopia lentis, aortic enlargement, or clinical score of 7 is enough. But obviously, the relative has to have a proven diagnosis. And so these are the systemic features that you score. And so, for example, if you have wrist and thumb sign, you give it a 3. You have a pectus carnatum deformity, you give it a 2. Hindfoot deformity, which is a lateral displacement of the posterior heel, basically. It gives you 2 points. Pneumothorax, dural which is a central nervous system process where they start having like symptoms from S1, S2, S3 nerve roots because of the dura not being able to give way, and so they have increased pressures there. That's a very difficult diagnosis to establish, but here are the other features. If you're tall and lanky, it's very hard to get 7 points on this. You really have to have features of Marfan syndrome. Here you have the classic ectopia lentis, which is up and away in Marfan. That's more of a geneticist question, but anyway. And you see the dilated aorta. This is how complicated it is to decide if a mutation in fibrillin 1 is causative. So I'm not going to go over this, but you can see that, if it's on the EGF consensus sequence, no point in going over that. But I put this slide on just to say, just because they reported a fibrillin 1 variant doesn't mean that someone has Marfan. Patients will need several referrals other than cardiology, so if you establish a diagnosis, medical genetics can help the patients sort of navigate where they have to go. So the recent RCTs showed that both losartan and highest-dose beta blockers reduced the rate of progression of the aortic dilatation in patients with Marfan. They used a very high dose of atenolol that is not the one that's normally used in clinical practice. So they may have sort of clouded the picture that way by getting so much response out of the beta blocker that they couldn't see a difference with losartan. But basically, now we know that both are better than nothing. And the aortic root must be replaced if greater than 5 centimeters or grows 1 centimeter in 1 year, or there's severe regurgitation. Some people say that you could do earlier replacement if the family history suggests early dissection, but that's not a firm guideline. And I put this table, which comes from a different paper, and they use a 45 millimeter cutoff for Marfan, but that is not the standard I've seen. Most surgeons use. Loeys-Dietz syndrome is very similar to Marfan. We're up to 4 types of Loeys-Dietz now, so I keep having to update this particular slide. But TGF-beta receptors 1 and 2 were the first 2 that were described and now are called types 1 and 2. SMAD3 is type 3, which has a history of early osteoporosis, particularly tortuous vessels. You see tortuous vessels in all of these, but SMAD3 seems to be worse than that. And TGF-B2 seems to be a milder form of Loeys-Dietz, but tell that to the patient that needs to have an aorta replaced, that it's milder. So it's not really that mild. But you see some physical, so they look like Marfan, but they actually have craniosynostosis, so early closure of the sutures in the skull, causing them to have hypertelorism, which is widely spaced eyes. Another finding on their midline is that the uvula is either very short or bifid. Bifid uvula is sort of the classic finding. The aortic dissection in low SDs can occur with relatively smaller diameters when compared to Marfan. They can also have enlargement of the pulmonary artery, arterial tortuosity, and aneurysms. We think losartan is beneficial because by blocking angiotensin receptors, you compensate for the excess signaling in the TGF-beta pathway, but it's very unlikely that we'll have a large RCT for losartan low SDs because there's just not that many patients. I mean, if it was very difficult to do it in Marfan, which is at least tenfold frequent than this. There are some other arterial dilatation and tortuosity syndromes. So vascular type EDS is a scary one. So this is caused by mutations in collagen type 3. And spontaneous rupture of arteries and viscerae, that means, for example, the uterus, especially after delivery, or the small intestine, colon after colonoscopy are frequent complications in vascular EDS, but sometimes it presents with a rupture of the subclavian artery and nothing else, and it can be obviously deadly. There are single gene causes of thoracic aortic aneurysm, such as the ACTA1 gene and MYH11. Those are the two more frequent. The list has grown in the past several years. There are some that we're not entirely sure about. There's one called MYLK that comes on and off the list all the time. Right now, I can't even tell you if it's on or off the list. There's arterial tortuosity syndrome, which is the only recessive cause of arterial dilatation and tortuosity, but these patients have fairly noticeable dysmorphic features and cutis laxa. Then an interesting one is autosomal dominant polycystic kidney disease can also cause arterial dilatation as part of the syndrome. So I'm going to talk about a few of the primary arrhythmias. So even this former internist can tell that this QT is prolonged. And so I'm going to talk about first long QT syndrome. So in genetics, we use the term Romano-Ward syndrome to characterize the purely cardiac form of long QT. So long QT without anything else. There's just a long QT. But long QT can be part of other genetic syndromes. And for example, Anderson-Tawil, which is characterized by periodic paralysis. Timothy syndrome, which hopefully I can get to, has cardiac, facial, and hand malformations. And then there's Javel and Lang-Nielsen, which associates long QT syndrome with sensory neural hearing loss, and it's actually the one recessive cause of long QT. So in Romano-Ward syndrome, usually presents a syncope caused by torsade de pointes. Events can arise from infancy to the 40s, but are usually seen actually in teens and 20s. And events are uncommon after 40 years. And if someone has an event after 40, that may be indicative of having long QT type 3. So what you will notice is that long QT type 3 is the one that's not like the others. Doesn't respond to beta blockers, has a particularly aggressive course, can present after 40 years. And sudden death is the initial presentation in 10 to 15% of patients. But the actual risk for patients that have been diagnosed and followed prospectively is only 4%. So here's the list of the official 12 genes that are related to long QT. And so they've been assigned each one a long QT genotype number, so 1 through 12. So the long QT, this is where it gets confusing. There's the long QT genotype, which is numbered 1 through 12, but there's also the phenotypes, which are only numbered 1 through 3. So there's really only 3 types of clinically distinguishable long QT, types 1, 2, and 3. And these other genes cause either a 1 or a 2 or a 3 phenotype. It's just a different gene. And it all has to do with the current, the ion currents in the cardiac action potential. So in long QT1, you block the phase 3 potassium outgoing channels. And that's why you have those particular electric findings in those patients. In long QT2, you block the phase 2 potassium channels. And in type 3, you increase sodium entrance into the myocyte. So when you divide it up in phenotypes, those are the 3 phenotypes, 1, 2, and 3. 1 is about 60% and 2 about 35%. And the genes that are most frequently associated with those are there. Potassium channel Q1 for type 1, potassium channel H2 for type 2, and sodium channel 5A for type 3. And so beta blockers are indicated in 1 and 2, and I've seen articles go both ways for beta blockers in type 3. Some even go on to say that they're actually contraindicated and might increase the risk of torsades. And this is what the ECGs look like. So you have that broad-based, tall T wave in type 1, besides the prolonged QT. In type 2, you have sort of this notch in the middle of the T wave. And in type 3, you just have a very late T wave. And type 3 has a very high penetrance, 90%. So remember about penetrance, whether if you have the mutation, you get the disease, but it's only relatively small. It's relatively small for type 1. Only 62% of patients with a proven mutation actually go on to develop the long QT. And then the resting EKG is the initial test, but it's not completely sensitive or specific. So I'll point out that 31% of patients that have long QT syndrome have an initial resting EKG that's in the uncertain range of 400 to 450 in men, 400 to 470 in women. So not everyone has a clearly positive EKG. Of course, if you have a prolonged QT, you guys know what to do, to rule out the normal stuff and then think about the rare genetic stuff. And then you can also do some provocative testing. If you do genetic testing, you can find mutations in 75% of families, and it can help you with the differential diagnosis and confirm the diagnosis when the EKG is uncertain. Avoid stuff like provocation testing. It's better to screen for at-risk relatives than the EKG because, again, EKGs can miss 30% of cases, at least in the initial EKG. And there is a little bit of genotype-phenotype correlation. So the course in patients with mutations in sodium channel 5A is so relatively poor and they don't respond to beta blockers that you really consider early ICD in those cases. So this is one situation where you order this gene test, you have this result, you take this different course of action compared to not having ordered that particular genetic test. So in my view, these patients should all have sequencing to prove their mutation. Timothy syndrome is a form of long QT caused by mutations in the calcium channel A1C, and these patients have also cardiac malformations, such as PDA, PFO, VSD, tetralogy Fallot. They can also develop HCM, and they have cutaneous syndactyly, so fingers fused together syndactyly, but spares the thumb, and 2-3 toe syndactyly. So toe syndactyly is when it's not only the skin that's joining the two toes, but the actual toes are basically, the bones are shared by the two toes. They can have facial dysmorphic features. 75% have developmental delay, and these patients need an ICD as soon as the body weight allows. So this is more of a pediatric presentation. So you see the skin syndactyly here between digits 4 and 5. This is the 2-3 toe syndactyly, and so you can see that this is more than the skin. Even part of the nail is shared between those two toes. And you see this pattern of T-wave alternance in these patients. Anderson to Will syndrome is periodic paralysis. So these patients have a mutation in a potassium channel called J2, and they literally periodically have generalized skeletal muscle paralysis, plus symptomatic cardiac arrhythmias, including a prolonged QT, enlarged U waves, and evidence of ventricular ectopy. And they can have dental anomalies as well, but not always, so I'll just not dig too much into that. And you say the U wave here, prolonged U waves in these patients. Brugada syndrome is sort of the mirror of long QT. The prevalence is between 0.6 to 0.05%, and it's all about the characteristic STT segment. They have a high risk for ventricular arrhythmias, and what was described in a book as incessant hemodynamically stable VT. And it primarily manifests in adulthood as syncope, but can be diagnosed as early as 2 days of age or as late as 85 years old. And there's a variant of this, which is the sudden unexpected nocturnal death syndrome that is seen in Southwest Asia, and it's just a high prevalence area of a particular mutation. And so the type 1, you see the very tall T waves, and the Cove type ST. And then in the types 2 and 3s, you see an increased J point in the wave, but the T wave is biphasic or positive. So that's the difference between those three. So here you see that the ST segment is prolonged, and then the T wave is actually inverted. Here you see that it is positive, but it still has the notch. So sodium channel 5A. So remember sodium channel 5A from about 10 minutes ago in lung QT type 3. It's the same gene that causes 30% of Brugada syndrome. And so what you have here is the opposite effect. You have a blockage of sodium coming in. So instead of a gain of function mutation in that gene, which is what you see in lung QT, you see a loss of function mutation in this one. Or you can have blockade of calcium channel coming of the calcium channel in phase 2 of the action potential. Or you can have increased egress of potassium throughout. So mirror effects from lung QT. And here's another example where a specific genetic test can change management. For example, patients with this particular mutation, histidine 558 to arginine, have a lower risk of sudden death when compared to patients that have the threonine 512 allele, which has a higher risk. There's actually an X-linked gene here, which is the calcium channel E5. And so, if your patient happens to be the second family reported with this, you have a case report in your hands, 1, and 2, you have a completely different genetic counseling for them. Then the last topic I wanted to cover was CPVT. So this is episodic syncope during exercise or after an acute emotion. And you see the onset of VT, which can be bidirectional or polymorphic. And it usually resolves but may degenerate into VFib. Usually it starts in childhood, but it can present into the late 30s, which is, by the way, true of every genetic condition. They ask me, what do you do in adult genetics? I see the stuff that should have presented as children but didn't. And up to 30% of patients may present with cardiac arrest. And these patients do not have structural myocardial anomalies. I'm going to skip a little bit here. Here you have the pattern you see on the Bruce protocol. But what I wanted to get to is it's actually an interesting mechanism. You have mutations in RYR2, which is a rhodine receptor, type 2, which controls calcium between the lumen and the cytosol in the sarcoplasmic reticulum. And basically, this particular receptor becomes leaky, and calcium gets out very easily. There's a recessive form of the disease because there's this protein called calcioquestrin, which holds on to the calcium inside of the sarcoplasmic reticulum, and if it's not present, then the calcium can also leak out. This is the same gene that has also been related to malignant hyperthermia. Again, because calcium here exposed by anesthetics starts to leak out. So, again, genetic testing can be used to confirm the diagnosis, can help you differentiate between the recessive and the dominant forms of the disease. Patients with idiopathic VT, even with a negative stress test, so the stress test usually brings up the VT in these patients, but even if a negative stress test, they may still have an IYR2 mutation. Some cases of SIDS in childhood have been associated with CPVT. Genetic testing can be used for carrier testing and for predictive testing. And if you identify a mutation in someone, then their first-degree relative should be evaluated with a genetic test first. Okay, 5 minutes. Whew. Thought I couldn't get through the whole thing. So, question 1. So, which is a true statement? Who votes for A? Incomplete penetrance means not all carriers manifest the same range of symptoms. Who votes for B? GWAS is a test with high clinical utility. C. Microarrays can identify point mutations. D. Mutations outside of the coding sequence can cause genetic disease. E. I don't know. Okay, so it's actually D. So incomplete penetrance to review means that not all carriers manifest the symptoms, period. When we talk about the range of symptoms, we're talking about expressivity. Question 2, which one has autosomal recessive inheritance? So you have Jervell and Lag-Nielsen, Brugada, Timothy, or Romano Ward. So it's A, Jervell and Lag-Nielsen. And 3, true or false, it is possible to be homozygous for mutations in genes that cause hypertrophic cardiomyopathy. It's true. So actually, and this goes into the nitty-gritty of details of genetics, we shouldn't really use the term autosomal dominant for something that you can have 2 mutations for, but we've sort of changed the definition of dominant to mean 50% inheritance for so long that basically we've stuck to the new definition. But using the Mendel's definition of dominance and recessive, then they really are, it would be codominant, not autosomal dominant. Okay, so thanks for your attention. Any questions?
We just have a couple of minutes. I'm going to ask a question while other people are thinking of theirs. If we wanted to refer a patient to genetics, what's the appropriate way to do that? How do we know if they need to see a counselor or a geneticist?
So practically speaking, right now we don't have a counseling clinic only. So the referral goes to clinical genetics. And there is a referral in the Emory system, or you can email me, or you can give the patient the phone number for genetics, which is on the website, which I haven't memorized.
Where does that occur?
Where is the clinic at? It's right now we're located off campus on North Decatur Road by Publix. But there's a promise that will be relocated to Clinic B in January. So, but for patients right now, it's pretty convenient because they have parking on site and they don't have to walk through a maze in the hospital to find us. So.
Could you comment on your thoughts of how rapidly things may change over the next several years, 5 years? I know in the field of heart failure and dilated cardiomyopathy that there are genetic tests that might identify whether a patient is at a high risk for sudden cardiac death, may or may not need a defibrillator, but the testing is very expensive right now. What do you project as far as what's going to happen over the next few years?
So the cost of genetic testing right now does not come from the technical part of the test. It comes from manually having to read after the computer has spit out 5 or 10 variants, someone has to look those up in the literature and figure out whether they cause disease or not. And so that's labor intensive. With the shared databases that have been developed, it's possible that that time and the cost of the analysis might come down. And there will be more genotype-phenotype correlations. But I don't think we're at the point where it's going to be a $200 test. It is, for example, for cancer genetics. But in this particular area, cardiac genetics, we have so many genes of uncertain significance, so many mutations that we're not sure about, that it might take a while to get down to that. The other thing that's going to happen is in the technical side of things is we will have developed, it's already in development, it hasn't been released to clinical use, what's called single molecule sequencing, which is going to reduce the need for these computers to line up all these different strands. It's just going to sequence the DNA as a single molecule from top to bottom without having to slice it and dice it, which is what you do right now. So testing costs will come down, but it's going to take a while for that to happen. If you feel that your patient needs a genetic test, unless they have a full exclusion on their policy, if you go through peer-to-peer or through appeals, you can usually get it approved. Especially if you have papers that will back you up saying, look, this particular mutation, I want to look for this because this has a particularly bad prognosis or this has a particularly good prognosis. So if you have that kind of thing, you can prove to this reviewer who has zero knowledge of genetics, I can promise you, that it's medically necessary. That's all they want to hear, that it's medically necessary. If your patient still can get tested, most labs have self-pay options, payment plans, etc. And so there's a lab called Invitae where you can get a cardiac genetic test done for $475. I have no money from Invitae. I just mentioned them because they're the ones that have this offered. But the patient has to pay up front, $475. Might not be a possibility for everyone, but for some patients, it might be something they want to consider. All right, thanks.
Thank you.
The preceding program is copyrighted by Emory University.